Endometrial carcinoma is the most common gynecologic malignancy in developed countries and typically presents in postmenopausal women. Endometrial carcinoma is classified into two main types: type 1, which is estrogen-dependent, and type 2, which is estrogen-independent. Type 1 accounts for about 80% of cases. It usually presents as low-grade endometrioid histology and arises from endometrial hyperplasia due to unopposed estrogen exposure. Risk factors for type 1 include obesity, anovulatory cycles such as in polycystic ovary syndrome, use of unopposed estrogen therapy, tamoxifen use, early menarche or late menopause, nulliparity, diabetes mellitus, hypertension, and Lynch syndrome. Type 2 is less common but more aggressive. It is not related to estrogen and typically occurs in older women with an atrophic endometrium. It is often associated with p53 mutations and includes serous or clear cell histology. The hallmark symptom is postmenopausal bleeding, present in over 90% of cases. Other symptoms may include abnormal uterine bleeding in premenopausal women, pelvic pain or pressure in advanced disease, watery or serosanguinous vaginal discharge, and constitutional symptoms like weight loss or fatigue in late stages. Initial evaluation begins with a transvaginal ultrasound. An endometrial thickness greater than 4 millimeters in a postmenopausal woman is considered abnormal and warrants further investigation. The gold standard for diagnosis is an endometrial biopsy. If the biopsy is inconclusive, a dilation and curettage or hysteroscopy may be performed. For staging and local assessment, pelvic MRI is preferred. CT scans or PET-CT scan may be used to assess for distant metastases. Staging follows the FIGO system and is surgical, requiring a hysterectomy with bilateral salpingo-oophorectomy and lymph node assessment. Treatment is tailored based on stage and histologic type. For early stage disease, typically stage 1 or 2, management includes a total abdominal hysterectomy with bilateral salpingo-oophorectomy and, where appropriate, pelvic and para-aortic lymphadenectomy. Adjuvant therapy may include radiation therapy, such as vaginal brachytherapy or external beam radiation, particularly for high intermediate risk cases. Advanced stage disease, including stage 3 and 4, is managed with debulking surgery, followed by adjuvant chemotherapy, typically with carboplatin and paclitaxel, with or without radiation. For select patients with early, well-differentiated estrogen receptor-positive tumors who desire fertility preservation, high-dose progestin therapy may be considered, along with close surveillance. Complications may arise from both the disease itself and its treatment. Disease-related complications include local invasion into the myometrium, cervix, or vagina, lymphatic spread to pelvic and para-aortic nodes, and distant metastases commonly to the lungs or liver. Treatment-related complications may include surgical risks such as bleeding, infection, or injury to adjacent organs. Lymphedema following lymphadenectomy. Radiation effects including radiation cystitis, proctitis, and vaginal stenosis. Chemotherapy-related side effects such as myelosuppression, peripheral neuropathy, and alopecia. And hormonal therapy risks including thromboembolic events and weight gain. If you found this video helpful, don't forget to like, share, and subscribe for more informative content. Stay tuned for our next video.